de minutos. Ok, ahí está. Hi, Gordon. Can you hear me? Hello. Hi, Gordon. Can you hear me? We cannot hear you yet. You are muted.
Okay, can you hear me now?
There he is. Okay.
Okay,
Hi.
great. Juan, hello.
Juan is also here.
Yeah, I see. Great to see you,
Hey, Gordon,
Juan.
how are you?
I'm doing well, thank you.
I'm
Okay,
good.
I
Yeah.
am remarkably enough under the circumstances that I just told you about, Yvonne, I am ready to go.
Okay, awesome. So, Gordon, I'm going to make a quick presentation in Spanish so they understand kind of the
Yeah,
rules of the
so,
game. Yeah.
So what are we? I'm a little disorganized. Are we in teams? Is that right?
Yes, we're in teams.
Okay, so I'm always a little. I use Teams much less, and so I'm going to need to share screen. So before you introduce me, let's make sure that I can share screen, if that's
sure.
okay with you.
Yeah, sure.
Okay, so I've hit share, and I guess I hit screen.
There it is, your full screen now, your PowerPoint now. Awesome.
Okay, brilliant.
Okay.
Do you want me, okay, do you mind if I stay sharing while you introduce me?
Yes, sure.
Okay,
Go
good.
ahead.
All right. Okay,
Yeah.
good. Go ahead.
Thank you, thank you. So, muy buenos días a todos. Como parte de las reuniones del grupo académico de epidemiología clínica, el día de hoy tenemos un invitado muy especial, pues yo creo que no hay mucho para presentar al profesor Gordon Gallat, que directa o indirectamente ha sido profesor de todos nosotros y ha sido un personaje clave en la medicina basada en la evidencia, en la epidemiología clínica y en muchas otras cosas. Para nosotros es un honor tener a Gordon acá, quien accedió a la invitación de hablar un poco sobre la medicina basada en la evidencia, el pasado, el presente y el futuro. Como esta sesión es en inglés y la idea es que Gordon va a hacer su conferencia y al final de la conferencia, de los 30 minutos que tiene a su disposición, estamos abiertos a preguntas, a discusiones. Si alguien del auditorio, digámoslo así, quiere hacer la pregunta en inglés a Gordon directamente, adelante. Si alguien quiere poner preguntas en el chat y yo trataré de traducirlas de la mejor forma para que él la entienda y dé su respuesta en inglés, esa es la forma en que trabajaremos de las 7:30, 7:35 hasta las 8 de la mañana que terminemos hora Colombia. Entonces, no siendo más, el profesor Gordon Gallat, que fue profesor mío, que fue profesor de Juan Manuel, aquí también presente, y que todos conocemos por su contribución a la medicina basada en la evidencia, es profesor distinguido de la Universidad de McMaster University en Hamilton, Canadá, y nos va a hablar hoy de la medicina basada en la evidencia, como pueden ver ahí, Past, Present and Future. Tiene 30-35 minutos para la conferencia y estaremos atentos a preguntas para la discusión al momento en que él termine. Les pido el favor de apagar los micrófonos para no interrumpir la sesión y le damos el micrófono a Gordon. Gordon, thank you so much for being here with us. This is a meeting that we regularly have for the clinical epidemiology group in my university, University of Antioquia in Colombia. And we are really pleased to have you here. Most of the attendants are people who are involved in the masters and of the clinical epidemiology, professors, students, and also clinical researchers in our field. And not only here in Colombia, but there might be some people that are outside of Colombia right now, like for instance, Juan Manuel, who is in Florida, among other people from the country, and even in Latin America that might be attending today. So thank you so much, Gordon. You have 30 to 30 minutes approximately. And after we finish, we are going to open for the discussion for questions from the people here. Some of them may be in Spanish through the chat, which I will try to filter and translate it to you to make things easier. But at the end, of course, some people might be able to do their own questions in English, so you can help us to answer them, okay? Gordon.
Okay.
Thank you so much.
So thank you. Evidence-based medicine, past, present, and future. First big apology. Sadly, I do not speak Spanish. So you're going to have to put up with my limitations and everything in English. As I go along, you may want to put, if anything I say is not clear or an idea occurs to you, you may want to put it in the chat as I go along. And Yvonne, you can keep note of it for when it comes to the question period. So here we go. So I'm going to take a historical approach to evidence-based medicine, which means I will introduce you to some of the people who have had major influence on its development and its progression. I'm going to describe what I think, as part of this historical approach, are the three key principles of evidence-based medicine, something about its evolution and its future. So this is the first paper in 1991 where the term evidence-based medicine appeared in the medical literature. And to give you an idea of just how long ago that was, that's what I looked like when this paper was published. My mentor was Dave Sackett, who was also a mentor of many of the subsequent leaders in evidence-based medicine and made many contributions, including coming up with this simple hierarchy of evidence for therapy. And this hierarchy, at the bottom of the hierarchy, is clinical experience. We recognize that clinical experience is a legitimate source of evidence, although it will only yield low or very low quality evidence. We have basic research, observational studies looking at patient-important outcomes, and at the top of this hierarchy of evidence, randomized trials. This is a very simple hierarchy, which served us quite well for over a decade. However, we now have a much more sophisticated hierarchy, which I will present to you as we go along. Probably everybody in this audience knows about the Cochrane collaboration, and many of you probably know that Ian Chalmers was the guy who came up with the idea of the Cochrane collaboration, and not only came up with the idea, but he provided the energy and political skills that were necessary to actually create the Cochrane collaboration and to get it moving in moving toward its goal of collecting all the randomized trials, putting them in systematic reviews, everything relevant to therapy across the broad field of medicine. I'm going to illustrate the importance of this activity with a couple of stories. One is about thrombolytic therapy after myocardial infarction. I'm sure all of you are familiar with these forest plots, but this is a little bit different from the one that you are used to. Rather than just a regular meta-analysis where each point estimate and confidence interval represent a single trial, this is a cumulative meta-analysis. Well, in this cumulative meta-analysis, the first study of thrombolytic therapy, the first randomized trial, enrolled only 23 patients and thus has a very wide confidence interval. The second one enrolled not 65 patients, but 42. In this cumulative meta-analysis, you have the number of trials and the total number of patients. Well, up to the fifth row there with 7 trials and under 2,000 patients, the confidence interval still crosses the null. It's not clear whether thrombolytic therapy is beneficial or harmful. But at 10 trials and over 2,500 patients, it no longer crosses the null. And the issue then arises, when was the answer in terms of the benefits of thrombolytic therapy after myocardial infarction. Well, if you look down by 30 trials and over 6,000 patients, the confidence interval is now a long way from the null, and the p-value is getting very low. And most of us might agree that at that point, the answer was in, and clinicians should have started offering to their patients and perhaps encouraging their patients in the use of thrombolytic therapy. Well, did people keep doing trials? Yes, they did. And if you look down by the end, there were another 40,000 patients enrolled in randomized trials of thrombolytic therapy after the answer was in, half of whom did not receive the life-prolonging benefits of thrombolytic therapy. We end up with a very, very low p-value and a very, very narrow confidence interval, both unnecessarily so and to the detriment of patients who should have been receiving thrombolytic therapy at this time. Well, why did this happen? I think the explanation is largely on the right side of the slide, with textbook and current review recommendations, which were happening as these data accumulated. And they say anywhere from recommending that thrombolytic therapy be administered routinely for specific conditions, calling it experimental, or not even mentioning it. And if you look down at the mid to later 1980s, you can see very much expert disagreement. Some saying routine, some specific, some experts calling it experimental, some not mentioning it. And it is a decade after the answer was in that finally you have a consensus among the experts. And I've talked to the trialists who were involved at this stage, and they said we just had to keep doing trial after trial to finally convince the experts about the benefit of thrombolytic therapy. This is a second story. It is also from myocardial infarction. And 45 years ago, when I was training in internal medicine, I rotated through the coronary care unit, and every patient who came through the door, I started what we called a lidocaine drip, an intravenous infusion of lidocaine. Was there ever any support from randomized trials for what I was doing? No, there was not. In this case, all the point estimates are on the harm side. As the data accumulates over 20 years, confidence intervals get narrower. We never establish definitively harm, but we certainly excluded important benefit. Did this stop the experts from recommending lidocaine? No, it did not. As these data are accumulating, most of the experts, as you see on the right, were recommending prophylactic lidocaine, and that's why I was giving it to my patients. But once again, you see very considerable expert disagreement, and finally, the experts got the message, and we no longer give lidocaine to people with myocardial infarction. So 2 stories about expert disagreement, experts a decade behind the evidence, experts making recommendations that actually contradicted the evidence. Well, these are old stories. They end about 1990. Something happened in 1990 to change the picture. Experts still disagree. They still get things wrong, but probably not so badly as they did in these stories. Think for a second, what happened in around 1990 to change the story so that this happens much less frequently? And the answer is systematic reviews and meta-analysis. If you go back before 1990, there were essentially no systematic reviews and meta-analysis. It is, in my lifetime anyway, I think of it as a relatively recent phenomenon, and it has clearly changed medical practice dramatically. So, third person to introduce you, Brian Haynes. Yeah, somebody said something there? Anyway.
No, someone, yeah, go ahead. Just someone open the mic.
Okay. Brian Haynes, who for 10 years was the chair of my department here at McMaster University, used to be clinical epidemiology and biostatistics, now health research message, which we call HEI. And Brian made many contributions, which includes this paper about physicians and patients' choices that made the point evidence does not make decisions, people do. And to illustrate that, I'm going to introduce you to someone else, PJ Devereux, who at the moment is changing the world in terms of perioperative medicine. But before he got into that, he did the study I'm going to tell you about. So he presented to about 60 patients and 60 physicians the following scenario in patients with atrial fibrillation. Patients with atrial fibrillation are at risk of stroke, and Dr. Devereux said without treatment, 100 patients will suffer 12 strokes, 6 major and 6 minor. Anticoagulation would decrease the strokes to 4, 8 fewer strokes, 4 major and 4 minor. And Dr. Devereux asked his participants, his physicians, and his patients, how many bleeds would you accept in 100 patients and still be willing to administer or use anticoagulation? So without treatment, 100 patients will suffer 12, reduced to 4, you prevent 4 major and 4 minor. And how many bleeds would you accept in 100 patients and still be willing to administer? Think yourself, 5 or fewer, 6 to 10, 11, 15, 16 to 20, over 20. How many bleeds would you accept and still be ready to use anticoagulants? Here's what happened when Dr. Devereux asked his patients and his physicians. Look at the physicians first. A flat distribution with great variability. Some saying less than 5 bleeds, quite a few 5 to 10, some to 10, 15, and a few over 15. I've reproduced this with many clinical audiences when I've asked them this question over the years, particularly internal medicine audiences. But look at the patients. 2/3 of the patients said they would be ready to accept 22 bleeds to prevent a stroke. Very different from the physicians. So the patients are much more stroke averse and much less bleeding averse than are the physicians. And so it becomes very evident we should use the patient's point of view and not the clinician's, patient's values and preferences. Patients much more stroke averse than the physicians. But there's a second message. If you look across this, although 2/3 of the patients are very stroke averse, there are a few who share the physician's values and preferences and are more bleeding averse and ready to accept very few. This tells us that if we want to get it right, we have to recognize the variability in patients' values and preferences and use shared decision-making to target the patients to get the choice right for each individual. Andy Oxman trained with us at McMaster, was with us for about a decade before going to Norway, where he resides at the moment. And it was his idea to come up with GRADE, a system to judge our certainty and estimates of effect from systematic reviews of the evidence and moving from evidence to recommendations. Very successful. Over 120 organizations worldwide have adopted GRADE. I told you earlier on about Dave Sackett's very simple hierarchy of evidence. This is now GRADE's considerably more sophisticated hierarchy. Randomized trials start still as high certainty evidence in GRADE's classification of the evidence as high, moderate, low, or very low certainty, but it doesn't stay that way. Often, very often, it doesn't stay that way because there are problems or limitations in these studies, risk of bias, imprecision, indirectness, inconsistency, or publication bias. Observational studies start as low certainty evidence, and they may go to very low with the same problems, but they may be rated up if particularly for very large effects with interventions like insulin and diabetic ketoacidosis, epinephrine in anaphylaxis, or hip replacements. Those in each case, very large, relatively quickly acting interventions, and under those circumstances we have moderate or even high certainty evidence, even though we only have observational studies. So GRADE also gives an idea of how to move from evidence to recommendations. Very simple classification of recommendations, either strong or weak, with a synonym of weak recommendations, conditional. We give strong recommendations when benefits clearly outweigh the downsides, or vice versa. What can bring us from a strong recommendation to a weak or conditional recommendation? Several things, but the two key ones are low confidence in the evidence. If we have only low quality evidence, it's very difficult to convincingly say that the benefits outweigh the downsides or vice versa. But you can have high quality evidence and still make conditional or weak recommendations if the desirable and undesirable consequences of an intervention are closely balanced, because we've already learned values and preferences are differ. And when there is a close call between the benefits and the downsides, when people's values and preferences differ, some people are going to say yes to the intervention and others are going to say no. And under those circumstances, you make a weak or conditional recommendation. And that classification, that binary classification of strong or weak recommendations, we think is very useful. We make a strong recommendation conceptually when all or almost all the patients would make a same choice, a weak or conditional when they vary appreciably. Clinicians worldwide are time constrained. When I go around the world and ask audiences, clinical audiences questions, there is one question I ask, I always get the same answer. And the question is, do you have enough time to spend with your patients? Worldwide, virtually 100% of clinicians do not feel they have the time that they would like to have with their patients, which means we have to ration our time. A strong recommendation, if a guideline panel has got it right, if you went through full shared decision-making, all or almost all patients would make the same choice. Not a great use of your time. A weak or conditional recommendation is the situation where patients with fully informed would make different choices, and then you want to use shared decision-making. So guidelines can only use average values and preferences. At the point of care, we need to do shared decision-making, and we need decision aids to facilitate it. Victor Montori, professor at the Mayo Clinic, has done the best work in the world, in my opinion, on shared decision-making. He's a diabetologist, and his way of doing shared decision-making with his patients is to give them these cards. And with the various treatments that are now available for diabetes, he says, what to the patients, what would you like to know about first? Weight change, low blood sugar, how often hypoglycemia happens, how well it lowers your sugar, your daily routine, daily sugar testing, cost. And he asked patients to choose which card they would like. And which card do you think they choose first in the United States? Well, as it turns out, they choose weight change first, but they may then ask for daily routine. They may then ask about cost, and they may eventually ask about all six. But something's wrong with the slide changing here. Sorry, something has gone off. Oh no. This is awkward. I think I am going to have to get it back. Yvonne, you just sent me the presentation, and you sent me the thing. Where is the
The last
presentation?
one. It's lights there.
This one? No, this
Oh,
one?
that one.
Yes. Thank you, Yvonne. Sorry about this. I don't know what happened. Unfortunately, I'm still sharing, right?
But from the email, I think you need to
Yeah. I
download.
know. I have to open this. Come on, open. Okay, we are back,
Yep.
which is good. And we now want to go here. And we now want to go here. Great, we did this. And there, now it works. They may ask for all
Yep.
6, but they never do. They typically ask for 4 at the most, sometimes 3, even 2 is all they need to see to make their decision. This makes shared decision making very efficient. So shared evidence-based shared decision-making in 90 seconds with this wonderful innovation that you don't have to tell patients everything. They can choose to find out what's important to them. So it's very effective, and we're using that in our decision aids with our patients. Per van Veek studied with us for a year, and then on guidelines. And what he concluded is that guidelines they are often out of date, and we need to have living systematic reviews and living guidelines. And as one innovation in moving in that direction, he made an arrangement with the British Medical Journal to produce what we call rapid recommendations, where we identify recommendations that are out of date when new evidence comes along, and rapidly and efficiently produce updated systematic reviews and trustworthy guidelines, which are then published in the British Medical Journal. There are many of these now since 2016 when we started this, many particularly around COVID, but in a wide variety of other areas. And in COVID, we used another innovation in evidence-based medicine, which is network meta-analysis. Reid Semenchuk and Romina Brignardello led our living network meta-analysis of interventions for COVID, which informed WHO recommendations. So finally, moving to the future, or right at the cusp of evidence-based medicine, there's been wonderful, but I think we've lost the balance in simplicity versus methodologic sophistication. Cochrane risk of bias 2 is too complicated, with result low uptake outside of Cochrane, errors, poor reliability. We now have come up with what we think is a potential solution. We're calling it robust RCT, rigorous development, simplicity, 6 core items, and published very recently in the BMJ. And I'm obviously hugely conflicted, but I think this is people are going to see that this is sufficiently robust and is much simpler than Cochrane risk of bias 2 and should probably replace it. So next, in terms of the lost balance in EBM, grade has become too complicated. And the solution to that is what we call core grade. All you need to apply grade to paired comparisons of interventions. Deals with both systematic reviews and certainty of evidence from systematic reviews, as well as evidence to recommendations. 7 papers published in the BMJ on a weekly basis between April to June 2025. So hot off the press. So in conclusion, the 3 principles of evidence-based medicine are widely acknowledged, not always rigorously applied, but at least widely acknowledged. So those 3 principles, some evidence is more trustworthy than others, and evidence-based medicine, and grade in particular, provides a sophisticated hierarchy of evidence to decide where in trustworthiness the evidence is, grade being a major advance. Other principles include the need for systematic reviews. Grade insists on systematic reviews to inform recommendations, and then the role of values and preferences. And grade also provides an evidence to decision framework, moving from evidence to recommendations. But recommendations are only for typical or average patients. We want to get it right in the individual patients, and to do that, we need shared decision making, and we need decision aids to help. And through work like Victor Montori's, we are getting more sophisticated about producing the decision aids. Network meta-analysis has moved evidence-based medicine forward. We now have statistical methods for looking simultaneously at the wide variety, sometimes, of interventions that are available for a particular patient condition. And we have recognized that we can't summarize the evidence, make the recommendations, and as many organizations do, then congratulate themselves and sit back for 3 years before they update their guidelines. We need living guidelines that incorporate the latest evidence. And in my opinion anyway, we need to recognize that things have got too complicated. The experts in evidence-based medicine have got too taken with methodologic sophistication and not sufficiently attended to simplicity. Robust RCT and core grade are efforts to deal with that. So thanks very much. I am going to, if I can, on my screen a minute ago, it allowed me to, I saw stop sharing. I tried to click on it, and let's see if I go back here to Teams, stop sharing. There it is. Okay, have I stopped sharing?
No, it's still
Okay,
sharing.
help me. You see what's on my screen. See that stop? Well, let's see. I thought I could click on that stop sharing. It didn't work. So what do you think I should do? I'm clearly very non-expert. Let's see, I've gone here. Help me, Yvonne. How do I stop share? Oh, wait a minute. Top of the screen now, I see. Okay.
Got it. You got it. You got it.
Okay.
You got
You
it.
can see I'm a technical dope, but sometimes I manage by luck. Okay.
I know. Gordon, thank you so much. I will open the mic for questions. I think Fabian Jaimes is, go ahead. Fabian.
Thank you. Thank you, Dr. Gordon. It was very nice, your presentation as usual. I have a question, not about the future, but in the present. We have very frequently the experience of the patient who use the artificial intelligence, and they came to the consultation and say, this is my diagnosis, and ChatGPT told me that this is my treatment. So how do you envision the role of the artificial intelligence in the not the future, the present of the evidence-based medicine? And thank you for your presentation.
Okay, you're very, I appreciate your feedback on the presentation. Thank you very much. Okay, so now, as of a month ago, if you count from medical school, after 48 years in clinical practice, I've done my last rotation. So I'm no longer going to be the person dealing with the problems. So of the patient arriving with their AI solutions. And so you're really asked some things I know about because there's evidence. Some things like this are completely speculative. So the first thing I like to do when I'm answering questions like this is to say, as far as I know, nobody studied and it's been around sufficiently short a period of time. I'm not surprised if nobody has indeed studied how best to handle such situations. So ideally, we would have people studying how to handle such situations to do it optimally. Without that, it's pure speculation. So my speculation, the way I would speculate it is, obviously, you've got to start off by looking yourself and making a view as to whether the AI got it right. And maybe the AI did get it right. And in which case it will make things more efficient when in fact you are presented with an accurate diagnosis and the right ways of dealing with that in terms of patient management. But of course, the diagnosis may be wrong and the management may be incorrect. In general, hopefully one has established as a clinician or goes about establishing as a clinician a trusting relationship with the patient. And in that trusting relationship, clearly the patient has to respect the expertise of the physician, and you have to then address directly what the AI has said, what you think about it. It may be in many situations, if it's a condition that you're very familiar with or a presentation that you're very familiar with and you know the underlying evidence, you may be directly able to proceed and make a decision very quickly. Did the AI get the diagnosis right? And is this the right treatment? Or you may have to say, I have to think about this and look further at the evidence. So it is in the past, patients did come in sometimes with their own ideas, and then you have to respect that and deal with it in a understanding way in the context of trust between the physician and the patient. This makes it more challenging, but also makes it as an opportunity. They may, if AI starts getting it right, and one would expect AI will get it right more and more often. We're still in early days about how often it's going to get it right and what we can do to get it right. Well, and I have another suggestion. I have another suggestion of what you could do. Clearly, it is the getting it right with AI means getting your prompts right. And what we now in the near future, we should start teaching physicians how to do prompts with AI to get the recommendation right. So, for example, what is in this particular patient, what intervention should I give for their diabetes? Well, two things. Number one, you may want to use Victor's decision aid to see what's most important to the patient. But aside from that, you might put in simply to the AI your prompt, what medication should I use? Or you might put in, please tell me what the latest grade the latest guideline that has used grade suggests about the management of diabetes in a patient like this. You will get very different answers from AI if you just say, tell me what the best treatment is versus use the latest updated grade using guideline, okay? So another thing that occurs to me is say, okay, what prompt did you put in, patient, when you got your advice from AI? And you might well say, you have not been you have not been taught, you've not been taught to do the optimal prompts. And hopefully down the road, the clinician will say, I have been taught. Let's do it again together. You put in the right prompt to get it and see what comes out from that. That's another suggestion is what might happen in the future.
Thank you, Gordon. Juan Manuel.
Thank you, Gordon, for the presentation. Adding to the challenging scenario that Ivan kind of introduced, there is another element that is growing, and I don't know how it is going to impact not only the practice, but the future of evidence-based medicine. And it is the mistrust of science that is growing everywhere, in politicians, in policymakers, in patients themselves, the public. How do you see the future regarding the potential clash or synergy, I don't know, between evidence-based medicine and this mistrust of what science says about everything?
Okay, great question. And as a evidence-based guy, I have to know my limitations. So your question, to answer it, somebody should go to the literature and say what studies have been done about the political environment you're talking about how it impacts on people and what we might do about it. I am completely, I suspect there must be some literature out there. I am completely ignorant about it. So as a result, I should keep my mouth shut, right? Because to address questions intelligently, you have to know the evidence, and the evidence in regard to your question is completely unknown to me. So I think I should just be quiet about that particular question until I've reviewed the evidence.
Manuel,
I have another question, if you will. COVID posed a lot of challenges, among them the use of evidence to make decisions. How do you think evidence-based medicine did, or is doing, by the way, still addressing the many challenges regarding use of evidence to provide treatment to patients during the pandemic? I know that you have a talk about that, so I would like to listen from you.
Yeah. Well, that I feel qualified to comment on. First of all, I think we did remarkably well with respect to treatments. So how did we do remarkably well? First of all, the international community mobilized to do high-quality randomized trials quickly. We had big randomized trials of the vaccines, and we got the vaccines out very quickly. Second, we used the innovative technology for doing randomized trials, which are the trials in which you set up a structure of the trials and you run one trial after another, the platform trials. And we had a number of groups internationally doing the large platform trials. We had a lot of junk trials being done, which is a bit of a problem, but we had the large platform trials being done by various international groups. As a result, by the 2 years into it, we had three classes of medications that we knew reduced mortality in patients to severe and critical COVID, and we had three drugs that we knew were useful in preventing hospitalizations in patients with non-severe COVID. Very quickly, high quality evidence about effective treatments in both. And then we got the message about that we have to do, that the community, the international community was aware we can't sit around and use the usual pace about getting these things out. We have to do the systematic reviews. And as I've shown you, the network meta-analyses, there were two groups in the world, ours at McMaster and a group in France, who was doing living network meta-analyses, getting the information out quickly. And then we need to produce guidelines quickly. and I had the great privilege of working with the WHO with their guidelines, where we did get them out in a trustworthy way very quickly, and we made it. And the Magic Group, Per Van Veek and Thomas Agaritzis, Magic Group made a deal with the BMJ that the WHO guidelines would go in BMJ rapid recommendations. So you have a whole set of a large number of BMJ rapid recommendations, and the recommendations appealed simultaneously in one for one audience in the WHO documents and for another audience in the BMJ rapid recommendations. And I'm talking about the things that I'm most familiar with that I was involved in. But clearly this rapid production of the evidence, rapid putting it into systematic reviews, rapidly getting into guidelines, and as my impression, I don't know that literature as to how the uptake, but my impressions are the uptake as a result with good practice based on high quality evidence. So as far as that's concerned, I think we did very well. Public health, not so good, and I could talk about that as well. But in terms of the clinical, getting the interventions, developing the evidence, and getting the interventions, clearly the vaccines changed the situation completely. Anyway, I think we did very well.
Thank you, Gordon. There is one question in the chat before I open the mic to Milton. It was a little bit related, Gordon, to the first question from Fabian. I don't know if you are able to read it, but at the same time, someone else texted me about the tools, this kind of tool like UpToDate, because I know that you are involved in UpToDate. So you might wanted to answer the question about AI that Fabian did, but mostly focus on these specific tools that are very used among clinical residents to answer the usual daily questions, like UpToDate, but also a new tool, relatively new tool, which is called Elicit, is an AI-specific tool focused on summarizing scientific research. I don't know if you are aware of Elicit, but maybe if you are able to comment on this specific tool like UpToDate and maybe others specifically focused, rather than just ChatGPT in general.
Yeah, okay. So the insight that we had a long time ago about clinicians and evidence-based medicine was that clinicians will neither have the time nor the skills to evaluate the certainty of the evidence themselves. They're going to have to rely on other people to do that. And it may also be useful to provide them with guidelines, although ultimately, part of the guidelines I've told you about strong and conditional or weak recommendations, that in weak recommendations, they should recognize they should be doing shared decision-making. But at any rate, the bottom line is you don't expect physicians to process the evidence themselves. Guidelines are likely to be useful to them. So what they need to do is to pick the best guidelines in their particular areas. Now, I am enormously conflicted with respect to UpToDate. For the last 15 years or so, my job, I visit the UpToDate folks very regularly, and my job consulting with them has been to get them to be as evidence-based as possible. And I've succeeded to this extent. There are over 1,000 graded recommendations in UpToDate, and my job when I go in and visit UpToDate deputy editors who are producing this in collaboration with the clinical experts is to go through particular instances of challenging graded recommendations and get them to use grade optimally. So I obviously, after all this, have to believe that UpToDate is doing a reasonably good job. Of course, they could be doing better, a reasonably good job in producing evidence-based recommendations with these over 10,000 graded recommendations. So, but anything I say should be taken with a grain of salt because of my enormous conflict with respect to UpToDate. But yes, my residents are using it. I often am using it and think it's a reliable resource. I do not know the other one you are referring to. Maybe it's as good as UpToDate. Maybe it's better than UpToDate. In the end, maybe UpToDate will become a thing of the past, because all the AI will get good enough, and what we will teach people to do, we will teach people prompt engineering to use the optimal prompts that will actually get an answer for their specific patient that is a trustworthy answer. Maybe, we will see.
Thank you. And just for your knowledge, it is the link is in the chat for the tool, so you can check it, but I can share it later. Thank you, Gordon. Milton.
Okay, good morning or it depends your country. It's great to meet you, Gordon and Flores. I am Milton. I am from Peru, and I work as a physician. I have two questions. The first is, what is the main challenge in implementing evidence-based decisions in your daily medical practice?
Sorry, say again a little more slowly, please.
What are the main challenges in implementing evidence-based decisions in your daily medical practice?
Okay, well, in my past daily medical practice, which ended about a month ago, I'm trying to think. I'm having trouble with that one, and I'm having trouble because I, after my 45 years of practice, I got pretty good at it, or think I got pretty good at it, and I, in the clinical presentations that I saw frequently, I made sure I knew the evidence, and in the things that I didn't see frequently and needed to make a quick decision, I went to UpToDate. That in almost all situations, in any common thing, or not necessarily common in my practice, but there's enough of it that UpToDate has produced a graded recommendation. I got the answer. And if it was something that I had problems with, I worked as a general internist, then I consulted the subspecialist. And I fortunately was working in an environment where I had a good group of subspecialists who I could call on to help me. So I felt pretty comfortable. And if I say, what are the big challenges? I frankly have problems with it because I developed for myself ways of handling it that I was very comfortable with.
Okay, thank you. It's a good answer. And the second, when I started with evidence synthesis, I found many information about methodological or synthesis or mathematical methods, but no information about non-medical skills for evidence synthesis. Therefore, what non-medical skills should we all develop if we want to practice evidence-based medicine?
Well, as I said previously, maybe I'm not understanding your question, and then I'll give an answer to what I think it might be, and you can tell me whether I'm right or wrong. Okay. How many years ago? 30 years ago, or more than that, 35 years ago, in that vicinity, I took over as director of the internal medicine residency program. And as the director of the internal medicine, I had the naive notion that we were going to teach all the residents to look at the individual studies and meta-analyses, read the methods and results, and come to their own conclusion and process this. At the end of 7 years, running the residency program, I had recognized this is completely unrealistic. It requires skills beyond that people are going to learn in a residency program in terms of processing the evidence, and they don't have the time to do it anyway. So instead, we direct people to trustworthy guidelines. What we do need to teach them is how to understand the evidence. Right? They need to know what it means, what high certainty and what very low certainty evidence is, and things in between. And they need to understand relative risks and absolute risks, and how to interpret continuous outcomes, because they need that to do shared decision making. And that's what we should be focusing on. But they need to go to guidelines and evidence summaries, and they need to be taught how to interpret what emerges from guidelines and the associated evidence summaries. And that's why we're talking about UpToDate. That's why we're talking about AI. But, If it's a strong recommendation, maybe that's all you need, and then some guidance about how to give the intervention. If it's a weak or conditional recommendation, you need to be able to understand the evidence because if you don't, you can't engage in the shared decision making that is mandated when you have weaker conditional recommendations. Does that answer your question, or maybe it's completely off base?
Yes, thank you so much, Gordon.
Okay, I'll presume that I was close anyway. Thank you very much.
Thank you. So, Mateo.
Thank you, Dr. Ivan, for having such a great speaker for the meeting today. Thank you, Gordon, for the wonderful presentation. I was very much interested in asking you about a question of the role of observational studies for and their role in grade recommendations, because I noticed that you published a paper recently in the American Journal of Epidemiology. And one of the key takings that you mentioned is that, of course, the proper use of grade requires to clarify the intent of the question. And sometimes that is not very, very well known in some studies. So then you propose that we consider either to focus it as causation or as an association method. But of course, that would in some part impact the final assessment of the certainty. So how should we, with observational studies that have not a clear intent of the question, assess this? Because of course, if we would imply that the certainty of the evidence is high, that would have a different impact as if we could maybe focus it as a moderate. I'm not sure if the question is...
The question, I love the question. I love the question. Okay. Let me give you an illustration that I hope is the answer. First of all, by background. Grade has said, if you're interested in causation, that is therapy, what effect does an intervention have? Observational studies will start as low quality evidence. If you are interested in a study of prognosis in patients presenting in a particular way, what is their likely fate and what subgroups might there be with respect to their likely fate? Prognosis question, observational studies start as high quality evidence. And in a particular situation, you may be interested in the issue of causation, or you may be interested where observational studies will start as low, or you may be interested in a prognosis issue where observational studies will start as high. And let me tell you about an example I use from our own work that I did with a guy named Kari Tikkanen in Finland. And we looked at the issue of, does nocturia result in increased death rates? Getting up to pee at night, does it increase your likelihood of dying? Answer is it does. Okay. Observational studies have said people who have nocturia are at higher risk of dying. And when they were pretty good, a lot of adjustment variables and so on. That seems like it's probably the case. Now, the question is, are we to treat this as a matter of causation or as a matter of prognosis? Well, let's assume we're interested in causation. Let's assume that getting up at night, actually, you're at risk of falling, you break your hip. A lot of people, after the mortality after breaking your hip is high, you fall, you hit your head, and you get a subdural hematoma, and the mortality in subdural hematoma is substantial. Well, if that is the case, and so the getting up at night is actually causally related to the mortality, then maybe we should do interventions to treat the nocturia so people aren't getting up as frequently at night. Or we say, no. Which is probably more the case, very unlikely this is a causal thing. It's just that the getting up at night is associated with diabetes, associated with chronic kidney disease, associated with a lot of other things that actually are the cause of mortality. The nocturia is not causing the mortality, it's just associated with other things. If that is the case, it's going to be a futile activity, excuse me, to try to treat the nocturia. You may want to treat it for its inconvenience, but to treat it to lower mortality is futile. Now we're just interested in prognosis, and maybe people with nocturia, we should start looking at why they have the nocturia and find out things that are actually causally related and deal with those. So if we're interested in causation, if we believe it's you're tripping and you're hitting your head or you're fracturing your hip, then this is only low quality evidence, right? If we're talking about the possibility of intervening with the nocturia, the causal connection is very questionable. Likely it's not causal at all. Likely it's an association. So for causation, the observational study starts as low and might well go to very low. On the other hand, if we're just interested in the issue of prognosis, those observational studies start as high quality evidence. And so with the same data, if you're interested in causation, it's going to start low, might go to very low. If you're interested in association, it's going to start high, may go to moderate. So really, you need to be clear. Is your question a causation/therapy issue? In which case you're into observational studies start as low, may well go to very low. If you are interested simply in prognosis, then the observational studies start as high quality evidence.
Thank you very much.
You're welcome.
You.
I like that question. I find it an interesting issue.
Thank you. Is there any other questions from the people attending today? Okay. Otherwise, we are on time, Gordon. Just to wrap up, thank you so much for making time to share with us your experience with us. It's very important for us for the graduate students, for our programs to have you here. We are very pleased that you could separate your agenda for today. Thank you again to all the people who attend today. Gordon, I will share the core grade papers with the people over here through the mail. So that would be people would like to have more time to read through the core grade paper, because some of the concepts that you raised were also covered in those papers that were published very early to mid this year. Thank you, Gordon. Any last words? Oh,
just that it's been a pleasure talking to you. Thanks very much for nice things people have said about the presentation. Thanks for the great questions and comments. They were very good questions and comments, which I enjoyed addressing. So thanks very much. It's been a pleasure, a real pleasure meeting with you.
Thank you, Gordon. Take care. Muchas gracias a
Bye-bye.
todos.
Thank you so much. Have a good day. Thank you.
Gracias.
Dr. Gordon, thank you so much. A good day.